So we're going to talk about the rural residency program, and I actually asked Laurel, can I have a little bit of time on Thursday morning to talk about the program before we go into recruitment season, because people have heard about it, but you know, not as many details. And then she said, oh yeah, sure, you can have an hour. And I didn't feel like I really needed an hour, but since she gave me an hour and then she called it Grand Rounds, I decided I needed to really do some research on rural health, right? Rural health disparities, OBGYN, rural Wisconsin. So I've put together a talk that I don't think will last the whole hour. I'm going to leave some time at the end for questions for John and Jody and myself. And just so everybody's kind of on the same page about what we put together and what we're going to do moving forward as we go through this first recruitment cycle, because we're going to have one rural residency track spot, and that person's going to match this year and start next July. So, so that's what I'm all about this morning. Before we get started, I just want to tell everybody that I didn't really introduce myself, but I think most people know. My name is Hartenbach, and I'm a professor in OBGYN, and I've been here about 20 years, and I was at several other academic institutions before I came to this one, which is the most fabulous of all. And I have been the residency director for 3 years. Laurel asked me to do it about 3 years ago. And this rural track idea came up kind of quickly. So it's something that I didn't necessarily see coming, but there is a real need. I don't have a ton of street cred. I grew up in suburban St. Louis. But I have to tell you, I've been to every single site we're going to send residents, and I think I've been to almost every county in Wisconsin. So just to get an idea of the background of people here, who grew up in a rural community? Raise your hand if you grew up in a rural community. So that's a lot of people. That's a lot of people. And there's a lot of people nationally, and there's a shortage of rural health providers, physicians and other providers. So who can name the most counties in Wisconsin? Okay, here's a little competition. Okay, see how many you can name. Go ahead. Try it, Carly.
There's 72.
Can you name all 72? Does anybody think they can name more than Kevin? All right, Kevin's from Wausau. Okay, he wins because nobody's going to name any. You didn't even try. You didn't even try. Okay, I have one more, and that's basically from who thinks they're from the smallest community? Who grew up in the smallest community? Steve, how many people?
700.
700 people. Kathleen?
It was 1,000.
1,000. Okay. Klaus?
600.
600 people. Okay, here we go. Here we go. All right. Okay, so I think there's been a lot of interest in this program, and actually, the last time we opened up the applications and we had over 100 people apply for this one spot. So that's pretty exciting. It's pretty exciting. And I just wanted to kind of go over, my title is Wisconsin Rural Obstetric Workforce, What Do Women Need? It's really what do women and families need, right? Because OB is kind of it's the heart of our department, it's the heart of every family, and so it's what do the women and the families of Wisconsin need. And I don't have any conflict of interest. I try not to because I sleep better. And the learning objectives, we're going to learn a little bit about rural health disparities, the big picture. We're going to look at rural workforce in OBGYN in Wisconsin. We're going to try and understand Wisconsin and as it fits into the nation. And we're going to develop some knowledge about our new rural track. So in terms of rural health disparities, you could do an entire talk on this, but I just kind of pulled out from the literature because I had to do a lot of research on for this little talk, and I learned a lot. And I'm just going to share with you sort of the sort of overview of what I've learned. So rural communities in general have higher rates of preventable conditions such as obesity, diabetes, cancer, and injury, a lot of high-risk health behaviors, smoking, physical inactivity, poor diet, limited use of seat belts. The population in the rural communities is aging, tend to be a little lower socioeconomic status, higher concentrations of ethnic and racial minorities. And I think the thing that's most germane to this talk is that there are really strained healthcare systems and a lot of access to care issues. So I'm a data person, so I looked for a lot of data on exactly what's going on in OB in Wisconsin. And I was able to find some things. I wasn't able to find as much detail as I would have wanted, but the one thing that does come out is the access to care is really a barrier, and the number of people who get prenatal care in the rural communities is less, and that impacts their perinatal outcomes. So 9% of physicians practice in rural communities, and 20% of the population actually lives in rural communities. So, so there's right off, you see the disparity in terms of, you know, where the physicians are and where the people are. So here is a map. My first question, and Jody's done a lot of research and helped me with these things, and I was like, well, what does rural mean? Like, you know, there's all these, you know, Office of Rural Health, there's all sorts of national bodies, there's all sorts of state groups that are working on rural health issues, and I was like, well, what does rural mean? And what we came up with and what we figured out is rural means not urban. And that is actually that's how the feds define rural, is that it's not urban. Now, if you look at this map, these are some select rural healthcare facilities in Wisconsin, and what I find really interesting is the only thing, do I have a pointer? Maybe not. These are the urban areas. So the only urban areas in Wisconsin are around Milwaukee and southeastern Wisconsin, our area in south central Wisconsin. La Crosse is over there. The Fox Valley and Green Bay are there. Kevin, there's Wausau. And somebody knows what that is? I think that's Eau Claire. So those are the urban areas in Wisconsin. And so it's really quite a rural state. And this kind of just gives you a snapshot of where the facilities are. So critical access hospitals are hospitals that have been defined. Oh, I got a pointer. Thank you, Christian. Hospitals that have been defined to be in areas where obviously there's a critical access, and there are criteria for how they label something a critical access hospital. But those are the ones in the blue. Rural health clinics are labeled. The federally qualified health centers is a federal designation for underserved areas, not necessarily urban, or rural, and then skilled facilities. So, so you can see there's a lot of healthcare. There's a lot of rural areas in Wisconsin and a lot of healthcare that's needed there. In terms of national OB trends, what I found is childbirth is the most common reason to go into the hospital in the United States. Rural obstetrical care services have decreased dramatically. So the mid-'80s, which is actually when I got into the world of medicine, half of all the rural counties had some hospital maternity services, and this has really decreased. By the early 2000s, only 1/5. So 1 out of 5. So it was 1 out of 2 3 decades ago, and now it's 1 out of 5 that actually have a hospital maternity services. So the actual, it's not just physicians are less there, but there's less hospital services. So this is something, there's a lot of research going on in the world of hospital administration. In terms of the national OB workforce, this is sort of an interesting study that one of the family physicians did, because in rural areas a lot of the care is family physicians, but they looked at the MOC applications for all the physicians between 2000 and 2010, and there's a huge trend. Less and less family physicians are actually providing OB services. So in 2000, it was 23%, and in 2010, only 10%. So, you know, here's the graph. You know, we don't need the graph, but I like, you know, visuals and graphs, and that's a real decline. In the past, you know, family physicians were doing more OB. They were actually setting up fellowships to teach family physicians how to do C-sections, to really provide these services. But I don't know why there's been a trend since the turn of the century. Less and less family physicians are doing it, perhaps because more primary care things are being lopped on their plate. And I don't know, I haven't seen an analysis of the reasons, but this is a concerning trend to me. What they did see in this study was younger female US grads were the ones that were more likely to have OB in their practice. So just some interesting data about a big portion of the rural OB workforce. So what about Wisconsin? So the Wisconsin Hospital Association put out a report in 2010, and they called it the 100 New Physicians a Year, an imperative for Wisconsin. And it was actually published in 2011, but they did all the data analysis and writing in 2010. And they estimate that physician demand based on population growth and changing demographics in Wisconsin, there's going to be a shortfall of over 2,000 physicians by 2030. They think they need about 100 new physicians per year to keep pace with the demand, and that we have to make some significant changes in the medical education and training system in Wisconsin. So a couple of things have come from this. You may have read in the paper, the Medical College of Wisconsin is doing a Green Bay campus, and I think a Wausau campus, I know they've increased the class size here. There's some talk of an osteopathic school in Wisconsin. So the medical schools have kind of responded. At the GME level, it's trickier because you can't just start a residency program like overnight. There's limited GME funding. There's limited sites that are willing to take it on. There's patient population issues. In our field, there's minimum numbers, and a lot of technical fields, there's minimum numbers. So it's a lot. Our institution, we keep adding residencies and fellowships every year, and the director of GME says, we don't have funding for these. So there's a real rub there. But from this report, they really feel like there have to be more medical students trained. More of those medical students need to stay in Wisconsin, and we need to provide more graduate medical education programs for them. In terms of OBGYN, now ACOG does all kinds of workforce planning issues across the nation. So they do a analysis of every state. So here's what's going on in Wisconsin for OBGYN. There's 556 OBGYNs. This is data as of 2014, which is 2.3 per 10,000 women, which is a little below the national average, which is 2.65 per 10,000. So we're a little short on OBGYNs. There are actually always jobs in OBGYN in Wisconsin, and sometimes I wonder why don't more people move to Wisconsin, because I like it here. And it's actually, compared to other states, those of you who have been in other states and practiced OBGYN, it's actually a relatively pleasant place to practice obstetrics in terms of a lot of the environment, litigation, and so forth. So the female population in Wisconsin is supposed to increase by 7.8% by 2030. And here's the statistic that is the soundbite for the news, if anybody's seen some of the news coverage. So 26 of 72, or 36% of the Wisconsin counties, don't have an OBGYN practicing in their county. The thing I don't usually tell the reporters is that nationally it's 1/2 of the counties, so 1/2 of the rural counties. So we're actually doing a little better than the nation in terms of our coverage of the counties. But really, that's a lot of places that don't have an OBGYN in their community. And while others can provide obstetrical services, I believe to have a truly exceptional OB unit, you're going to be better off if you have an obstetrician along with your family physicians and your midwives and the occasional general surgeon that gets involved. So here's the color map of Wisconsin. So the no OBGYNs is this whole swath through here. All of those counties, no OBGYNs. Some of them even quite close to our neighborhood. You can see the place where there's 3 or more, Dane County, the Milwaukee area, all the same places where the population is. They are replete with OBGYNs. But in some of these other areas, not any OBGYNs practicing. This is the sort of partner map from ACOG, and this is basically how long do you have to drive to get to a maternity center. So just as you would expect, the populated areas, it's going to be less than 15 minutes, all these areas in red, less than 30 minutes. But 60 minutes is basically in these areas where less hospitals, less physicians, and drive times are longer. I didn't find any data in Wisconsin about does this drive time impact perinatal care? But I did find an interesting paper from Canada, and they have data that drive times affect perinatal care. But for Canada, drive times, they don't measure them in minutes, they measure them in hours. So if you're over 4 hours from a maternity center, you definitely have some decreases in your perinatal outcomes. So I did look at the DHS, which is the health department in Wisconsin, and they just issued the report on the annual Wisconsin birth and infant mortality. And I was looking for rural health data. And I think I need to partner with somebody in Pop Health, and I've already spoken with Deb. Are you here, Deb? Yep, spoken with Deb a little bit about digging into the data a little bit more to try and analyze Wisconsin. But this is their summary statement. This is what they do track on a regular basis, which I found was interesting. And basically, number of births per 1,000 women are steady in Wisconsin. The birth rate for teens is really interesting. It's just continues to decline since 2000. The preterm and low birth weight graph is really interesting. In the summary, in the words, they don't say anything about the trend, but when you looked at the graphs, that's actually climbing in our state and all across the nation. And I don't practice OB or perinatology, so I don't, I'm not going to comment on that, but I found that kind of interesting, and I assume it's because we're providing more care to younger and younger infants. But that's been steadily increasing. Infant mortality, no change. Obviously, the thing that we know, because it's been publicized a lot in Wisconsin at the medical school, it's the Life Course Initiative, the African American infant mortality rate is just way too high. It's 3 times that of Caucasian. And so there's a lot of work on that. I could not find any clear aggregate statistics on the reproductive outcomes for rural areas. As I said, it's something that we're going to work on. And then the last really interesting thing that they spend time doing is they do spend time figuring out what are the most common names on the birth certificates in Wisconsin. So in 2015, Emma and Noah were the most popular names. So the rural obstetric workforce, there was actually an interesting paper, and I didn't put a million slides in, but there's the public health group, the rural public health group in Minnesota, did a pretty decent, not just decent, a really comprehensive analysis of rural workforce issues in 8 states. Kind of the ones you might guess, Minnesota and Iowa and Colorado, but Wisconsin's also included. So there is some in-depth data. The Wisconsin data sort of tracks with the rest of the states, so I'm just going to present it in aggregate. And what they did was they did a phone survey, and they literally talked to 306 rural hospitals in these, I'm sorry, it was 9 states, not 8. And they basically figured out that in low volume hospitals, those that have less than 240 deliveries a year, much more likely to have the combination of a family physician and a general surgeon, doing the obstetric workforce, whereas the higher volume hospitals were more likely to have OBs and CNMs. And that's kind of true as you look at this overall, in terms of the number for all the hospitals, an average of 4 OB providers to 3 family practice providers. So family practice providers are doing a lot in these rural areas, but in the really lower number hospitals, much more likely to be family physicians, whereas in the higher volume hospital, much more likely to be obstetricians. And that kind of makes sense, right? Because if you're an obstetrician, you have to have enough work to be an obstetrician and to stay there. And so they're going to be in the areas that have enough volume to sustain their practices. So midwifery is another interesting thing, and there was a separate study on midwifery. There was a recent analysis excuse me, of this same data set. So the CNMs attend about 1 out of 3 of the rural births. There's some variability based on the practice regulations for the state for midwives. And if they're in a state that has autonomous practice regulations, they do 34%. But even in those that don't have autonomous practice regulations, they do 28%. So it's not a huge difference, but there's some difference if they are actually certified in a more autonomous way, which is sort of a regulatory issue. They tend to pair with OBs 86% of the time, and with family physicians less so. And it makes sense to me. I mean, if you're going to practice obstetrics, you need somebody with the surgical skill set for those occasions where nature is not so friendly. So rural hospital administrators, definitely a comment in this was that they were going to be looking to get more midwives to the rural areas. And I think that's true of all the workforce providers, get more people to these hospitals. So what are some of the barriers to physician recruitment and retention in rural areas? This was a paper published recently in the Journal of Healthcare Quality and Assurance, and they were just basically looking at kind of what are the challenges and what are the things that seem to work. So in terms of challenges, people are concerned about lifestyle and limitations on activities, concerned about school quality, medical practice. Some people are concerned that if they practice in a rural area, they're going to actually have longer hours, more on call, less access to specialists, and that the health of the population is going to be less, so it's going to be harder work. And then there's some competitive issues. The payer mix is going to differ in different places. But in terms of efforts to recruit physicians into rural practice, some of the successes have been if people have a rural background, they're 4 times as likely to practice medicine in a rural area. And if they have exposure to rural health and training, so there are a number of different rural health medical school training tracks. The Wisconsin program is called the WARM program. I think most people are familiar with it. Who here has been through a rural health track in medical school? Anybody? I know Kathleen, Janessa, Laura. Yeah, University of Washington. Kristen, are you too? No, somebody up there raise their hand. But if you have exposure to working in a rural community, you're more likely to take up practice in a rural community. And then I like this, the successes of people who are self-actualized and have a sense of place and community engagement, and that they want to be a bigger part of the community, tend to want to practice there. And obviously, the spouse has everything to do with where you end up practicing. So ACOG has a workforce sheet. They've got a committee opinion on rural health disparities. They've done a lot of work in this regard. And their general recommendations are to promote sustainable collaborative models with other OB providers, which makes sense, improve practice efficiency, encourage more medical students to pursue OBGYN. And we've been pretty successful with that lately. We have 10 this year. And we've been in double digits for several years. And another interesting fact is the applications for OBGYN, while they were going down a decade ago, have been on the rise since 2010. And it's become more competitive, not less competitive. Accommodating lifestyle, that matters no matter where you live, and flexible scheduling and practice patterns. And then publicizing loan repayment. People may not know there are loan repayment programs in Wisconsin that will do loan payback for people who choose to practice in rural areas. There's some interest in bills and legislation at the federal level to try and get some of those places qualified for the what's the name of the big program for loan? That. Yeah, thought you knew you guys would know. So they don't have on this sheet the increase training in rural environments, but maybe they'll add it to the sheet, because we're going to be the first program in the country to have a rural track. There's been a lot of rural tracks in family medicine that's been going on for a decade or more. And there's a lot of interest at the ACGME on rural tracks in specialty care. So how can we build our specialty residency programs to have some kind of rural experience, so that we can do what seems to make sense, is give people an experience in a clinical setting, in a rural clinical setting, so that they can envision themselves. I mean, what's it like to practice with 1 or 2 obstetricians rather than a group of 5 or a group of 10? And just, you kind of have to have that experience, because we also have data that wherever anybody does their residency, they're more likely to stay in that area, because they get used to it. They understand the program. So here are the top 10 rural medicine programs in 2016, and I think we've got people from all these places. Washington, shout out to Washington, New Mexico, Oregon, Minnesota, Colorado. Do we have oh, we kind of have somebody from Colorado. Wait, where did Aaron go? We need somebody from Colorado. We have we definitely have no-deckers here, not in current training, but we've had plenty in the past. So we came up number 8, Vermont. We're tied with Vermont. We have definitely some good Vermonters here. So these are the top rural medicine programs, and so I think it's fitting that we should be the place to do the first OBGYN track. So just to give you a little bit of background, it really started with an idea in 2014. Honestly, it started with Laurel's idea. The DHS gave some grants out, and the psychiatry department put a rural track together, and the surgery department put a rural track together, and Laurel said, well, we need to have a rural track, and I said, I just am learning how to run the residency. I've just been doing that for a year, so like, could we just do this another time? And you know, anybody who knows Dr. Rice well will know that you don't wait on these kinds of things. The good thing about Dr. Rice is she pushes you out of your comfort zone. Or maybe that's the bad thing. I don't know. But when she pushes you out of your comfort zone, she usually has your back. So she's been super supportive. And John actually is the one who, in those early conversations, said, you know, yeah, I can write a grant. I can write a grant for that. So you know, hats off to John. He got this RPAP grant. We got this RPAP grant, which is basically a Wisconsin Residency Assistance Program grant to basically develop the idea, not to wholly fund the idea, but to develop the idea. And because of that, we were able to hire Jody Lund, and then we were able to get approval last year through the GMAC Council, which is the first hoop. We recruited all the rural partners last winter, and we went on field trips, John and Jody and I, around southern Wisconsin. Then we got the ACGME approval last spring. ACGME is provisional approval. It's a pilot program. We get to have one person a year. As long as everything goes well, we can either continue that one or maybe grow it from there. And the ARS opened just this month, and then next summer we're going to have somebody. So I don't have a whole lot of details on the program, but I want to give you just the snapshot. We developed the program, but the devil's in the fine details, which we're going to be developing over the next year. So here are the places where the rural resident will go. Portage with our alum, Brenda Jenkins, which is going to be a great experience for them. There are 2 OBGYN physicians in Portage. Watertown is another place, a partner of ours, Dinesh Siddiqui. Is Ahmed here? Ahmed. He was the residency program director over at Aurora, and now he's practicing in Watertown with 2 or 3 other physicians. What does it say there? Yeah, 2 other physicians. So 3. So we've got 2 experienced residency educators, which I'm pretty excited about. We also have our partners down in Monroe. There are 3 physicians at the Monroe Clinic. Of all the places, they have the largest number of deliveries, so they're at 498. The smallest is the combination up here. So there's 1 physician in Waupun and 1 in Ripon. What was it, Carly? Waupun. Waupun. I can't say Waupun. Waupun. Okay, so Waupun has 118 deliveries. Ripon has 42. Together, they're the Agnesian Health System, and they're both pretty close. So we basically were looking. I felt like we should find places that had good obstetrician gynecologists that were within an hour drive of Madison and that had that qualified. So for the purposes of the various grants and things, 20,000 people or less. That's how they define a community as rural. That's not the sort of official Fed definition, but 20,000 or less is what RPAP says. So all these communities fit that bill. And we designed it so that they're going to come back on Thursday. So they'll be here Thursday morning, they'll do their continuity clinic on Thursday afternoon, and they'll be on site at the rural hospitals Monday, Tuesday, Wednesday, Friday. And we're going to show you a little video, just so you can meet some of the docs that are involved.
This rural residency program, which we have begun, and we're the first in the United States, is set up to recruit individuals who want to work in rural Wisconsin particularly. I believe that this will have a tremendous impact overall on the care of women in the state and their families. So much of what happens for health care in a family begins with the woman. To provide this kind of care at this time of her life and to start our babies out on the right foot is just so very important.
Wisconsin's a rural state, and there's a lot of communities that don't have OBGYN physicians. The new program, the Rural Residency Program, was conceived to really address those needs in a new way so that the residents have skills in those areas and experiences so that when they go to practice, they're actually able to be more effective. We have it set up so that they get the very best training, the very best the university has to offer, the Madison community has to offer, but also working with some of our regional partners so that they get some significant training in the community hospitals that they're going to ultimately practice in. Our goal is to recruit the best and brightest medical students. They'll be very much a part of the UW family. They'll know all the faculty here. I see it as just residency plus.
I'm originally from La Crosse, Wisconsin. Despite being in a small community, in a rural community, we have a very busy practice here. We have all the technologies available to us that you would have in a tertiary care center. Also unique to Monroe Clinic, despite it being in a rural community, is we have a strong teaching background.
I saw an opportunity for Ripon Medical Center that had not had women's health care in 10 years, I believe it was. I think the most important thing a medical student would want to consider if they're considering a rural practice is whether or not they'll be happy living in a rural setting. Medically speaking, I think that you have to feel fairly confident in your knowledge and abilities to practice in a rural setting.
We came here, we spent the day learning about Waupun Memorial Hospital and Indonesian healthcare, and by the end of the day we were quite taken with the practice opportunity and with the community. I think the most important thing that the resident will see is that you can provide great care in a rural setting without all of the other specialists surrounding you. I really think the biggest difference is not technology, but the people. We have all the technology that larger hospitals have. The advantages of being part of the community, where a part of your role is you're the OBGYN in town. It really is very rewarding.
I just love Madison. I've never been here. And I really got into the whole Madison spirit. One of the things that drew me to this program that has completely lived up to my expectations is the excellent surgical training here.
I love living here.
Okay, so in the future we'll have some rural track residents, but thank you very much for those of you that participated. So I just wanted you to see what some of the physicians that we got recruited said, you know, because actually I would be kind of daunted by going somewhere where I was the only obstetrician in town. The guy from Waupun. He said he's on call all the time, but it doesn't bother him at all. It's like he's not that busy. So, you know, like there's different practice models. I mean, you can be like crazy busy on call, like, you know, less often, or you can be on call more often and be not as busy. But you know, that's not going to work for everybody. But it was just interesting, and these are good OBGYNs, and I think that they'll do a nice job with the training. So just to give you the really 100,000-foot view, we're going to flesh out all the details on the rotations. But one of the themes is that we set it up so that they're going to stay in Madison for the first year, so they get all that OB experience that everybody gets in the first year, and that when we send them to the smaller communities, they're going to have more experience. And then through their second and third year, they're going to be off-site basically half of each of those years. And then they're going to come back in fourth year, and we're going to make sure that they have all the skills that they need, get all the cases that they need. And so the whole design is basically to have 75% of their training in Madison and 25% of their training in the smaller community hospitals. So rural health disparities exist in all the specialties. Wisconsin has a shortage. Rural background and medical training in rural sites are the two biggest predictors. And maybe this small program, which could grow, will help alleviate the problem here. And I know there's a lot of interest in other residency programs to try and do the same thing. So we'll see where it goes. It's starting small, but it's a big project to make this kind of change. So I absolutely need to thank Dr. Laura Rice, who is self-nicknamed as the Honey Badger. Okay, so just so everybody knows, this is not my nickname for her. This is her nickname for herself, and she has earned it. And really, hats off to John Street and Jody Lund. And we have a group of residents that are helping. Carly and Patrice and Ashley and Kathleen are helping as we develop like the details, because as everyone knows, the devil is in the details. And I just am going to end there, and then Jody and John and I can take questions, and then we'll have plenty of time to break before Steve. Thanks, everybody. Questions? Mary.
Question. I just want to applaud this whole program. I think it's phenomenal. My experience with rural, other than I live rural in Wisconsin, between here and Monroe, is in northern Wisconsin. And if we have any hope of addressing those access issues, I think this is exactly the right way to do it. Exposing folks and letting them see that, yeah, I can live this lifestyle in terms of, yeah, so I'm going to call every third or every night. It's not something undoable because it's not anything like what it looks like.
Well, yeah, well, when you do the math and you say, well, I've got 100 deliveries a year, that's like one every 3 days. I mean, that's a lot different than the call that, that groups in Madison are taking. So
nonetheless, the rural settings support the care of a patient maybe a little bit differently.
Yeah, I think so. I think so.
But the other thing that I wanted to say is I think that for the whole residency program, and it was the gentleman from Ripon who made this statement, to go into a rural community, you really have to have confidence in your skill set because you don't have an OBGYN colleague to consult with who's close.
Right.
So in terms of how we address all of our residents in the 4th year, I think that it is an opportunity to inspire all of us to allow the 4th years to hopefully have a little bit more independence in decision making, including in the OR, where we really are trying to sit back, let them do the basic surgical cases, not the super uber complex things, but our basic cases, and be in the room as their consultant, so that they really have the opportunity to make intraoperative decisions so that they can leave this program with the confidence that they could go out in a rural community and actually do this, because having mentored residents for the last 20-ish years, that is the biggest barrier that most folks feel as they leave residency, and it has progressively become more of an issue that they just don't feel confident that they can go out and function alone in the community with a general surgeon and family docs as being their colleague.
Well, medical training has changed, and the rules have changed. When I trained, there wasn't any kind of rule to have a faculty in the operating room. And of course they should. I wasn't saying we should go back. That wasn't my point. My point wasn't that we shouldn't go back. We should go back. My point is that I agree with you. I think we need more cases where the 4th year is walking the junior resident through the case and the faculty is stepping back appropriately in the appropriate situation, in the room, scrubbed or not scrubbed, all those kinds of things. And northern Wisconsin is gorgeous. So, Steve?
A couple of questions. One, there's no obligation for the rural track resident to actually practice in a rural setting, correct?
No, there's not an obligation, but I read a lot of papers on rural tracks, and most of the places get either half or 2/3 of the graduates to choose that on their own. There isn't, in our program, there's not a, you have to, and most of the programs don't do a you have to, because, I don't know, it's a little,
I was curious because my goal in life as a medical student was to be an OBGYN in Newcastle, Indiana. Clearly far afield from that setting, but so you just never know what you're going to.
Well, exactly. Yeah.
The other question is, what about who pays? Do you guys pay for travel? How do they get a travel stipend to get these places?
Yeah, we have the grant. The grant's helping us in the beginning. The Madison hospitals are covering the time here, and we're working on the funding, the sustainability funding, and yeah, that's all included. The reason we chose close is we wanted to be able to bring them back each week. I think ideally some of these sites in northern Wisconsin would sort of be on the on the list, or in some of these less populated areas, but we just kind of have to start somewhere. And I hear you. I applied to residency and I thought I wanted to be an MFM. Yeah. I mean, I have the paperwork to prove it.
Just to talk a little bit more about what Mary brought up, do you the expectations for somebody going into a community like this have to be pretty high? Do we want them to have even a higher bar of what they can do? Do we make sure they're surgical? And we want everybody to be good when they leave, but without partners, without any kind of infrastructure to help them, they're really going to be on their own. They have to really almost be better.
Yeah. I think we're actually trying to build it in. In fact, at the CCC meeting, we just talked about trying to build in some kind of a observership at the end of third year to kind of certify the fourth years for kind of independence, if you will, in a variety of the technical skills. So that we're already moving towards that, and I think that is the same type of thing that we'll want to see. We have a lot of people that actually have graduated and done things like this, not necessarily going to be the only OBGYN in town, but I don't know, Kevin Benson, he took off, and I mean, yeah, Alex Maminoff. We have a whole bunch of people. But I think that it's really important, what you guys say. They have to be confident and skillful. A lot of these physicians actually practiced in larger communities and then moved to these smaller communities. So I think we'll have to pay attention to that. Other questions, comments, Katie?
Are people applying specifically to this track?
Yeah, we had a lot of conversations about how should we do that. Ryan and Jackie and the residents and I, we decided to let everybody apply to both, and then or apply to just one. So of the ones that we have applying to the rural track, there's only 4 that are only applying to the rural track. So we're actually going to look at those applications even closer. Because they're pretty committed, and there's going to be a lot of people. What they had in general surgery, and what I think we'll see, is a lot of people are going to apply to both as a way to try and get in the program, right? Because it's a competitive program. So, Greg, did you, or Amanda?
I just answering the question that interviews. What is the housing situation going to be like for them? So are they going to be provided with the rural tracks, or are they going to have to commute every day?
So in my perfect world, they can choose. Jody, we've got housing set up at a couple places. Jody's like on the street with these people. So what do you have any comments on that?
So Monroe actually has student housing. So they actually have a medical school. So they will be able to stay in the student housing when they're there. And the other sites, they'll have the option to stay at a hotel.
Yeah, we'll do sort of an extended stay hotel kind of thing. So, Jake?
One of the things, like you mentioned, like that ACOG promotes in terms of recruiting the OBGYN task force was like collaborative models.
Yeah.
Like when you look at why there's been such a decline in access, it's really not because there's been a change in OBGYNs, but it's that attrition of family medicine providers who are doing obstetrical care over the last 50 years. But like when you go to these sites around Wisconsin, are there places in Wisconsin that are doing collaborative care either with nurse midwives or family medicine providers that are doing it really well that we can?
And in my dream, you know, we could work to figure out what is the collaborative model that works. This amount of deliveries, this amount of OBs, this amount of midwives, this amount of family doctors, you know, like, but right now, if you look at the data for Wisconsin, it's basically just patchwork, you know, as I said, and I don't know that anyone's written or described sort of, you know, the perfect OB team, you know, because we're even leaving out the nurse anesthetists and the anesthesiologists and the nurses, because in the smaller hospitals, they have to be cross-trained. They're labor and delivery nurses one day, and then they're going and doing med or surge the next day, because they don't always have somebody in labor. So it's the whole workforce thing is, once you start looking at it, it's more complicated than you even imagine. Back in the back.
Question, you know, when you're at medical school, you want to do rural track, and there's that rural opinion that kicks in. I was curious, like, if they sign up for residency track that's rural, could they, like, join on to that track at that point, or would that qualify for some of their?
Did you say loan repayment?
Yeah, when you do
Yeah.
medical school, you sign up for like a rural loan repayment.
But that may be unique to your medical school.
There are different programs like that.
Yeah.
And so, like, they have this commitment after they're done.
Yeah.
Residency. I was just curious if we thought about, would that apply for their residency, or would they get something like that?
That's a good idea. I don't know. That's another person to hit up for funding.
Well, they're joined in residency, could then keep them in rural.
Yeah, there are loan forgiveness programs in Wisconsin to keep people in. There's 2 different programs currently in Wisconsin to do loan forgiveness for people who practice in the rural sites. But I don't know about the rural rotations in residency.
And if they came, like, if they weren't signed up for that medical school, but they committed to it in residency, I wonder if there'd be a way to swing it that then if you did 3 years after your residency in a rural place, they would keep them.
Yeah.
And, you know, as an incentive to go do that.
Yeah, no, I think that's a good idea. That's a good idea. Let's see where we are. I don't want to steal Steve's time because he's pretty fabulous. Okay, other questions?
The funding is to go to the rural hospitals that are currently offering maternity care, and or maybe not, maybe all the rural, and see if they would be willing to support through a fund, through the department, some of the resident expenses, like travel.
Yeah, that's a good idea.
That's going to be real.
Yeah, we're also looking for a grant from, who are the dairy people we were talking to talk to?
Oh, I don't think it's going to dairy people, but there's a federal grant that is coming up that we
Yeah,
could
but it's a
possibly
way to engage
the hospitals.
State
Yeah.
with we're doing this, and in an effort to try to support, hopefully, the people who practice rurally in Wisconsin, and really raising an awareness that we're doing this. And then that will, you know, through, you know, even students applying to medical school, oh my gosh, there really are these things like general surgery, rural tracks. Rural tracks.
Yeah, there's an interest in at the medical school in particular to have us build out a track like this in all the specialty areas. Lauren, did you have something?
Yeah, are you hoping that this resident is from Wisconsin? Like, do you want this person to stay in rural Wisconsin, or what if they want to go to rural Wyoming?
Well, my first dream is that they practice in rural Wisconsin. My second dream is that they practice somewhere rural. So you know, we had a sort of a group about what's the perfect applicant, and you know, the perfect applicant is from a underserved area in Wisconsin and came to the WARM program and did well in the WARM program, and then decided they want to do OBGYN. I mean, that's like the perfect applicant. But you know, do we not want to, you know, train people for rural areas in other states? Well, of course we do. It's just that there's, you know, some of this is using state dollars, and so there's an interest in that. I'll just take one more. I thought I saw one more. Yeah.
So the other trickle-down effect of this, or trickle-over effect, is I don't think we should look at it as not meeting our goal if the folks that identify in the rural track choose not to in the end.
Oh, well, no, we're gonna, if they go anywhere rural, that's good. In fact, if they graduate and do well, we're gonna claim that as fabulous.
It's going to have maybe unintended consequences, but I think it can be anticipated is simply their exposure to Monroe and how practice is there in Waupun and Ripon and Portage, et cetera. They're going to be talking with all 20, whatever number of the residents it'll be then. And they will be raising an awareness, and so there will be others who likely will see themselves as more able to practice, and it's not quite so unfamiliar.
Exactly.
So I think the potential by developing this is huge, and not necessarily only impacting that person who's, you know, identifying that they want to do this. But I think we probably will get more residents who see this as doable.
Yeah.
If
Yeah.
not now, in 3 years or.
Perfect. Okay. Thanks, everybody. Let's take a break and come back at 8.